So next, the second speaker is Dr. Liu Ying from Shanghai Towako Hospital, China. So she graduated from China Medical University in 1992, and she got PhD in medicine in 2003 at Tsukuba University, Japan. Her title is Efficacy of Delayed Oocyte Retrieval in Patients with Challenging Oocyte Retrieval. So, Dr. Liu, please come on the stage.
Good afternoon, everyone. I'm Liu Ying from Shanghai Towako Hospital. Here is a pleasure to share our work on delayed oocyte retrieval in challenging IVF cases. We hope for our findings offer new insight and practical strategies for patients with poor retrieval failures. Our focus is on high-risk group, DOR, advanced age, and recurrent IVF failure, where conventional approaches often fall short. We propose a tailored delayed retrieval protocol as a potential solution, which I will walk you through today. We conducted a retrospective analysis of IVF cycles from August 2024 to March 2025. Patients were grouped based on retrieval time, conventional group and dilated group. We compared outcomes including oocyte retrieval rates, embryo quality, and pregnancy result. We divided patients into two groups based on retrieval time and NSAID use. The dilated group received NSAID and underwent retrieval after 38 hours post-trigger. Both groups followed standard stimulation and culture protocol tailored to individual history. We analyzed 90 cycles in the conventional group and 322 cycles in the dilated group. Most had secondary infertility, and many present with DOR or advanced maternal age. Baseline profile were balanced, allowing meaningful compression. Mean age and AMH was similar, about 38 years old, 0.41 ng in the conventional group, and in the dilated group, age is 39 years old, AMH is 0.35. The confirmed group homogeneity and supports the validity of the outcome comparison. Oocyte retrieval outcomes showed clear advantage in the dilated group. Retrieval rate improved from 57% to 65%, with fewer field cycles. More oocytes were retrieved, and the premature ovulation dropped sharply from 15% to just 6.8%. High-quality blastid formation improved significantly, about 65% in the dilated group versus 27% in the conventional group. At our center, blastocyst culture is applied into two conditions. First, suboptimal day 3 embryos. Extended culture is used for embryos not meeting the cryopreservation criteria because the patient have low reservoir function and our older mature age, so they hope to continue culture. And another condition is high quality day 3 embryos. These are primarized for blastist culture, offering more reliable insight into development potential. The deleted group showed a significantly higher clinical pregnancy rate and lower miscarriage rate. Biochemical pregnancy rate was similar, as many patients are still preserving embryos for future transfer. So ongoing follow-up will provide further validation. This case highlights a patient with 9 years of infertility. Her ovarian reserve declined sharply. AMH dropped from 1.21 in 2018 to 0.51 in 2023. Key challenges included low oocyte yield, poor fertilization, and sharp potential embryo quality. The patient IVF journey spanned 22 field circles across external clinics, marked by recurrent implantation, failure, and biochemical pregnancies. At our center, initial attempts with conventional retrieval also resulted in presentation failure. All 4 embryos obtained through deleted oocyte retrieval were high quality, which 2 achieved successful pregnancy after transfer. For patients with poor embryo quality, we typically cryopreserve cleavage stage embryos on day 2. Let's review the treatment details that yield these 4 embryos. In the 18th oocyte retrieval cycle, a minimal stimulation protocol was employed. At 20 hours post-trigger, 75 milligrams of diclofenac were administered orally, followed by retrieval at 38 hours post-trigger. This resulted in 2 high-quality transferable embryos, which are currently cryopreserved for future use. Due to the favorable treatment outcomes, the same protocol was applied in the following months. Ovulation was triggered on day 35, and the oocyte retrieval was performed about 38 hours later. Yet another higher quality cleavage stage embryo on day 2. Subsequent embryo transfer resulted in a successful pregnancy. Due to the patient's poor ovarian response, after 2 unsuccessful cycles, we proceeded with embryo transfer. In this cycle, a fresh embryo transfer strategy was adopted using a retrieval-based protocol. Oocyte retrieval was performed about 42 hours later, yielding a high-quality grade 2 full cell embryo, which were transferred with the cryopreserved grade 2 5-cell embryo. This transfer achieved successful implantation, ultimately resulting in the birth of a healthy baby girl. This case struggled with infertility for 11 years, marked by repeated empty follicles, premature ovulation, and failed embryo transfer. Her AMH is correctly low at 0.51, and her cycle were highly irregular, ranging from 26 days to 50 days. Let's dive into the patient's journey. After 3 failed frozen embryo transfer at external clinics, all ending in implantation failure, she came to our hospital, and we shifted strategy using deleted oocyte retrieval. We retrieved 8 mature eggs, which developed into 3 high-quality embryos. One is cryopreserved. The grade is 8 cell, grade 2, while other 2 embryos was transferred fresh. Let's renew the protocol of these 2 cycles that successfully yield embryos. For the second oocyte retrieval, the minimal stimulation protocol was employed. Trigger ovulation at 41 hours, resulting in 8-cell grade 2 embryos, which were subsequently transferred and successfully implanted. The pregnancy is currently progressing well. In the third oocyte OPU cycle, a retrieval protocol was used, with ovulation triggered at 40 hours. This results in the retrieval of 1 8-cell grade 1 embryo, originally planted for fresh transfer. The embryo was cryopreserved due to the patient is very anxiety about implantation failure. Following another freezing FET cycle, she achieved a successful pregnancy, which is currently progressing well. Our observations indicate that oral diclofenac administration significantly extended the oocyte retrieval window, with some patients undergoing retrieval as late as 50 hours post-trigger. For the majority of patients, retrieving time is now optimized with 40 to 44 hours post-trigger, indicating enhanced flexibility and precision in follicle metro management. Let's see the figures. For case 1, conventional protocol, about 12 OPU cycles resulting in 9 failed embryo formation and 3 implantation failures. Deleted protocol reduced to 5 OPU cycles with only 1 implantation failure and 1 miscarriage. Case 2, deleted protocol, despite 8 OPU cycles, only 1 miscarriage occurred, indicating better risk management. The deleted protocol constantly improved embryo transfer potential, even with fewer initial oocytes. This suggests that timing adjustment in ovarian stimulation could improve outcomes. Traditional ovarian stimulation protocol tightly regulate LH level to control ovulation. In contrast, our deleted egg retrieval technique used Oocyte to inhibit COX-2, thereby reducing the release of PGE2 to delay follicle rupture. So how do we determine the precise egg retrieval timing for each patient? We use our estrogen dynamics model. On the day after trigger thought, we often perform the blood test to measure hormone levels. If estrogen hasn't dropped, we proceed with the standard retrieval schedule. However, if the estrogen has decreased by 50%, we advanced the retrieval and performed it the very next day after the trigger. Oocyte inhibit COX-2 in reducing PGE2 to delay ovulation and improve oocyte maturity, extending retrieval time about from 38 to 50 hours, enable tailored schedule, increasing yield and embryo quality. Process evaluation control enhance art success and clinical outcomes. Patients with difficult egg retrieval often have only one dominant follicle, but sometimes there are small ones. Standard thick needles may miss these eggs, but using thinner needles like a 21 gauge or 22, 23 gauge can successfully retrieve the oocyte, including mature ones. At our center, we usually use Kitazato's 21 gauge needles for smaller follicle retrieval. As many of our patients face such challenges, where there are follicles, there is a hope. Our post-retrieval rate to 66% and cause premature ovulation to 3.8, far below the usual 15%. Over 65% of embryo now reach high-grade blasted quality, more than double the previous 27%. It's a safer, more effective solution for tough cases like low reserve or older age and past IVF failures. Thank you for your attention.